So thank you so much. Thank you to Marla and Uma. It's always a pleasure to come back to San Francisco and be amongst my mentors and my very favorite people. I'll be discussing healthcare maintenance for the inflammatory bowel disease patient. And while I know this might not seem like the sexiest topic in today's agenda, I'm going to argue that actually maybe next to Dr. Kiefer's psychosocial factors, that actually healthcare maintenance is probably one of the most critical factors that will allow for your patients to stay long-term on your treatment plan, stay long-term on your medications, and hopefully stay in remission. So I often think of our role as IBD providers as sort of a tightrope walking act where we're balancing the complications and the risks of the disease, bleeding, anemia, colon cancer, with the risks of the therapies that we're prescribing. So namely, infection being the biggie, as well as non-solid cancers and various hematological and metabolic complications. So who is responsible for monitoring and trying to prevent these complications from arising? Well, I'm going to argue that it's probably, at this point, these are complex patients, the need for a team approach. And whether or not we like it or not, many of us are often the only physicians that really our patients are seeing because many of our patients are young, they don't have any other comorbidities, and they see us much more frequently. Many of my patients don't have primary care physicians. And if you ask them, they would really want their gastroenterologist to be their primary care provider and have it be a one-stop shop. Furthermore, in several survey studies up to date, most PCPs report not feeling comfortable providing routine preventative care for IBD patients. So in this one study of internists and family care providers, upwards of 70% of PCPs did not feel comfortable giving recommendations for vaccinations for these patients, obviously a very important healthcare maintenance step. And as a result, IBD patients actually probably receive less preventative care compared to non-IBD counterparts. And these are the patients that actually require it the most, probably. And it seems like probably the trend, given the way that CMS and payers are sort of emphasizing pay for performance and quality measures, that the predictions is that the formal responsibilities of preventative care may start to shift to us as gastroenterologists. And I'll talk a little bit about quality measures to kind of frame the talk today. So just as a show of hands, who is already reporting PQRS for IBD patients? Show of hands. Okay, so actually probably the minority of patients. So just to sort of refresh you on what PQRS is. So the AGA actually created a task force and worked with CMS to create certain quality measures that will be part of that are already part of a voluntary reporting system, where gastroenterology practices can report their performance, their individual performances on certain measures that are considered important in the care of IBD, hepatitis C, and colorectal cancer. And this is a voluntary system technically for now, although already CMS is starting to implement penalties in terms of reimbursement, decrease in reimbursement for your Medicare patients for poor performance on these quality measures. So what are these measures for inflammatory bowel disease? Well, there are 8, and if you can see, actually, as I highlighted, the minority, only 2 of the quality measures have anything to do with the direct treatment of IBD, and the majority actually have to do with preventative health care of these patients. So to focus on infection prevention, which is actually encompasses 4 of the quality measures. First, let's step back and look at what the magnitude of infection risk in our patients. So this is a summary of the infection adverse rate risk rate in 2 large trials of combination therapy. So the COMMIT trial compared infliximab plus and minus methotrexate. And you can see there was not a very significant difference between the 2 groups, but the overall infection risk was quite high, over 50%, and this is only within a 1-year clinical trial period. The SONIC trial, as we are well aware, compared azathioprine and infliximab monotherapy with combination therapy, and you can see that the serious infection risk was highest in actually the azathioprine monotherapy group, and then pretty comparable in terms of the biologic, the infliximab with or without azathioprine. And then in one meta-analysis of a pediatric groups, you can see that the infection risk was pretty similar. So in terms of trying to prevent these infections, it's an important sort of selling point when you're talking to a patient that you might need to sell an immunosuppressant, I find, to tell them that though there is a higher infection risk with immunosuppressive agents, that many of these infections are preventable. However, the vaccine response in patients who are on immunosuppression, as you imagine, as Uma showed also in the pregnant population that's on immunosuppressives, that there is a lower vaccine response rate. So this seems to be sort of more common with biologics or a combination therapy, and multiple studies have shown that patients who are on biologics or combination therapy have a lower response to the influenza, the pneumovax, and the hepatitis B vaccines. Immunomodulators seem to be more of a mixed picture, but in the majority of studies, it does not seem, at least for monotherapy, to affect vaccine response rates. So combined with the fact that these patients have an increased infection risk and a lower ability to mount a response when they're already on immunosuppression, it's generally recommended that a good vaccine history is taken on diagnosis at your first visit with these patients, and then routinely every few years. Patients are currently seeming to be under-vaccinated throughout the country, so there have been multiple studies that have shown that although influenza vaccination rates about a decade ago were quite low, those are increasing up to 80%. However, pneumovax and hepatitis B vaccination rates still continue to be quite poor at less than 50%. Part of this reason is probably, again, we're not still consistent enough about taking vaccination history. So in one survey of gastroenterologists just published in 2 years ago, only about half of us routinely perform a vaccination history. And only about 12% of us, although I know no one in the room is included in this number, could correctly identify the vaccinations that are appropriate for patients who are immunocompetent versus those who are immunosuppressed. So just to go over some of the key vaccinations, those that apply to all patients and which actually are included in the CMS Quality Measures are influenza every year for all patients regardless of immunosuppression status, and then pneumococcal vaccine at least once. And that's just to fulfill the CMS Quality Measure. In terms of the overall pneumococcal vaccine strategy, it's actually recommended by the infectious disease societies that all IBD patients, regardless of immunosuppression, should get pneumovax, which is the 23-valent or polysaccharide vaccine, once at baseline and then 5 years later. In those patients that are immunosuppressed and in those patients that are over the age of 65, it is now recommended that these patients get sort of a booster or the Prevnar conjugated 13-valent vaccine. And the timing of this is a little bit confusing. I actually I'm not quite sure of why the rationale, but the Prevnar should actually be given either first, and then you should wait 8 weeks later to give the pneumovax, or you should wait an entire year if the patient already got a pneumovax before you give them the Prevnar. So, and it's been shown that this sort of improves the response rate to the pneumococcal immunity. So in terms of the other vaccinations, this is sort of a summary from the CDC website. And this actually was just updated this year, although just with minor modifications. This is for the general population. And then the second table, which is usually more applicable for most of our patients, actually includes sort of specific recommendations for those with immunocompromising conditions, including the immunosuppressive medications that we use. And you can see the main difference between that first table and this. The striking difference are these 3 red bars. And what are these red bars? So these are the live vaccines, which are contraindicated in all immunosuppressed patients. And immunosuppression is defined here or by the CDC as prednisone greater than 20 milligrams, any biologic. Azathioprine and 6-MP, as well as methotrexate, are a little bit more controversial, a little more gray, except in the case of Zoster, which we'll talk about. And the theoretical concern is, of course, that these live inactivated vaccines can cause disseminated disease. So what are the live vaccines? So the ones that we think about on an everyday general population basis are varicella, zoster, and measles, mumps, rubella. In your patients who are trotting the globe, typhoid and yellow fever are also live vaccines, which shouldn't be given to immunosuppressed patients on biologics. If you are going to be giving patients any of these vaccines, you should try to ideally wait 4 weeks before starting on an immunosuppression. So just one special emphasis on the Zoster vaccine. So Zoster is probably the most common opportunistic infections in our immunosuppressed patients. So obviously Zoster infections increase with age, and actually this is a graphic of the incidence of Zoster in IBD, and it does seem to occur at higher rates overall in IBD patients, Crohn's more than ulcerative colitis, not controlled for immunosuppression, and at an earlier age. Now, the risk with immunosuppression has been pretty well defined, so it seems that the overall risk is about 1.5-fold higher overall in the IBD patient population. And it actually is interesting, azathioprine and 6-MP is associated with the highest risk of zoster at 3-fold over patients who are not on these drugs. So in terms of zoster vaccination recommendations, for the general population, it's over the age of 60. With the knowledge that IBD patients are at increased risk, some groups do, and I do sometimes try to get vaccinations approved for those above the age of 50, as long as they're not on the Infectious Disease Society defines as high immunosuppression regimens, which is prednisone greater than 20 milligrams a day, biologics, or full dose immunosuppression. In those cases, zoster is still contraindicated, but in all other patients, sort of advocating for in a case-by-case basis for vaccinations over the age of 50 is probably warranted. So just to summarize sort of general vaccination considerations, the 4 things to check in terms of if patients have titers, meaning they do have immunity, and this has become more and more important because, as you know, we in the room are probably some of the last people to have actually gotten chickenpox, for instance. And so most of these childhood immunizations, by the time that patients are actually being put on immunosuppression, oftentimes have waned or are actually undetectable. So in all patients at your first visit, regardless of what immunosuppression they're on, I would recommend checking an MMR, so rubeola, mumps, and rubella IgG, as well as varicella, hepatitis A, and hepatitis B, and then vaccinate accordingly if it's not contraindicated. The other vaccines that you should think about, regardless of immunosuppression, are listed here on the left. And then, of course, you have to think twice about the live vaccines, which are, once again, just to emphasize, MMR, varicella, and zoster, and those patients who are on immunosuppressive therapy, or you're planning to be starting on immunosuppressive therapy within 4 weeks. So just to quickly go over the other quality measures which CMS is monitoring, one is some of the formatting didn't transfer, but 2 other infection prevention core measures are number 7 and 8, assessing for hepatitis B status, and also latent TB before anti-TNF therapy. And I know since everyone in the room is already doing that, I don't have to sort of go over that in any more detail, other than to say that quickly there is some increasing evidence that quantiferon over PPD is more accurate and probably more cost-effective than PPD, in which patients have to come over oftentimes more than once for these skin tests, which can be falsely negative or positive, depending on if they're on immunosuppression or if they've had BCG. So CMS quality measures also include a measure about bone health. And this is important, of course, because we know that upwards of 25% of IBD patients can have osteopenia and osteoporosis, probably related to history of steroids, but also potentially an effect from systemic inflammation or vitamin D malabsorption. The current recommendations for a DEXA scan to assess for osteopenia or porosis are in patients who have had a prolonged steroid use history of greater than 10 milligrams per day for greater than 2 to 3 months. All IBD patients over the age of 50, men and women, those who've had trauma fractures, and those, and you want to consider it obviously in patients who are malnourished or women who are amenorrheic. Smoking cessation, obviously important, especially in your Crohn's disease patients. I don't usually actually provide help for smoking cessation. I always discuss counseling, but of course, some of the most effective medications for smoking cessation are psychotropics, so I don't usually feel very comfortable myself prescribing or managing these, but it's an important and a CMS quality measure. And then finally, the quality measures don't include cancer prevention, but this is obviously an important area of preventative care for our patients. So I don't have to remind everyone in the room that obviously colon cancer surveillance is indicated in patients with ulcerative colitis or Crohn's colitis after 8 to 10 years of disease, and then immediately and annually in PSC patients. But the 2 sort of biggies that we need to counsel our patients on, especially who are on immunosuppression, are cervical cancer, which it's well documented that patients on immunosuppression, particularly the immunomodulators, have an increased rate of abnormal cervical PAPs as well as cervical cancer. And so the ACOG recommendations are that any woman on immunosuppression should have PAP exams annually. And then skin cancer is sort of a big topic in IBD because it definitely does appear that immunosuppression is associated with an increased risk of mainly non-melanoma skin cancer. So thiopurines are the big one here, where there's probably a risk with these medications of skin cancers of 2 to 3-fold over those who are not on these medications. And then combination therapy, actually, these patients have the highest risk of skin cancer, like 4-fold or so. And so I generally recommend most of my patients on immunosuppression be seen by a dermatologist. This is sort of one suggested guideline of skin cancer screening. You can see the majority of people can probably have skin exams every other year, but it is on an individualized basis. So this is obviously a lot of steps to go through with your patient who you're seeing for 20 to 30 minutes each time, and largely focus on their bowel symptoms. So with our EMR systems and with tools such as the Cornerstones checklist, which I can put a big plug in for because my patients, it's very effective in giving this checklist to the patient so they can see what they're sort of responsible for trying to sort of achieve. And it gives patients, I think, a little bit of feeling of control over of preventing complications with their medications. And then they can take this to their primary care doctor and sort of just have these filled out. But tools like this are important to help us remember all of the healthcare maintenance needs of our patients. So in conclusion, healthcare maintenance of IBD patients is increasingly seen as the responsibility of gastroenterologists. While PQRS is voluntary now, it's predicted by many that they will sort of be adapted into formal pay-for-performance models and sort of medical homes. The key vaccines to encourage and document if you want to fulfill quality measures are influenza yearly and pneumovax at least once. Make sure to obviously check your Hep B and latent TB status in patients you're starting on anti-TNFs. Remember to check bone DEXA and encourage smoking cessation in relevant patients. And that's it.